It's now my pleasure to introduce Stephanie Dancer. Actually, a lot has been said about dancing during this meeting. And we have been said this morning by Didier that we would have surprises today, so maybe something to expect from you? No. Anyway, Stephanie has been working all over the world in an incredible number of places, and she's now in NHS in Scotland. And as you have seen from the slides of the previous speakers, she's really a well-renowned expert in this field. And the title of her presentation is Novel Strategies for Cleaning and Monitoring the Effectiveness of Environmental Cleaning. Thank you, Stephanie.
Thank you. Thank you, Giorgio. Can everybody hear me before I expire from this around my neck? Well, congratulations, everybody, because this is the one session this week which is the perfect antidote to hand hygiene. Yeah? I need to qualify that, really. And it's the hand-touch equation. Because, of course, hands are only important because they touch something. And that is quite often is something in the environment. All you've got to do is sit on a ward and watch. You watch where the hands go. And I would maintain that there is not enough emphasis on cleaning. I think we've got an awful lot to do before we approach the 1,000 papers on hand hygiene in the latest hand hygiene guidance that we can see internationally. If you try and find the papers for cleaning, it's a bit more difficult. Well, somebody asked a question, I think he's disappeared, that's a shame, so I was going to answer it for him, about why don't we just accept that cleaning is important and get on with it? Well, yes, okay, but there's been a long battle to get to this stage, an entire symposium in an international conference. Wow. ECCMID hasn't got there, so some congratulations to ICPIC. But there are some reasons, and I've summarised them here. Cleaning has always been taken for granted. You can't necessarily just not clean a hospital, and Marcus made that point very well, that patients expect a clean environment. Of course, it costs money. The single biggest cost to the NHS is people, and people do the cleaning. So it's expensive, and if there isn't any scientific evidence, the first thing the managers are going to do is cut the cleaning roster and cut the cleaners themselves. And we've seen that in the UK when this battle actually started. Of course, we can't see the microbes. You have to get that through to the politicians as well as the managers. They don't realise that MRSA is not a blue flashing light bouncing up and down in a corner saying, wipe me away. You can't see them. And yet there is enough MRSA, enough Clostridium difficile on a single button to infect not just one patient, but probably all the patients on the ward. We've always got problems in NHS hospitals with fabric and maintenance. I'm sure you have too. Nothing destroys a cleaner's incentive more than seeing cracked paint, chipped linoleum, curtains falling to pieces. It still looks grubby even after you've spent an hour trying to clean it, and they don't usually have an hour. We haven't got much evidence. I presented this slide maybe about 10 years ago, and I remember saying there is no evidence for the role of cleaning in controlling hospital-acquired infection. In actual fact, now I can say there is little evidence. And it's because, of course, cleaning has never been regarded as an evidence-based science. And there's a really good reason for that. How do you measure how clean a hospital is? How do you measure how hard an individual cleaner works? Very difficult. How do we know that cleaning makes a difference? Well, the assessment of cleaning is something that I'm going to concentrate on in this talk, because I'm going to leave the detergent versus disinfectant for tomorrow. More of that later. Well, you've heard about this already, and this is actually some of the best evidence we have got for the role of the environment in hospital-acquired infection, and that is that if a patient goes into a room which was previously occupied by one infected or colonized with any of those organisms that you see there, then there is an increased risk that that new patient will acquire that specific organism. Now, this is regardless of whatever is going on with hand hygiene on that ward. So 100% of hand hygiene compliance on that ward makes no difference to the risk of the patient going into this room. Isn't that a marker for the importance of the environment? I think so. This, of course, is Phil Carling's review from last summer in AMGEC. And one important point to make about this is our support for the role of the environment in hospital-acquired infection. And when Phil published this, I think there were about 30-something studies. And of course, if you add that up now, I think it comes to about 45, because I keep updating it every time I show it. There you go. You can read through exactly what the papers are in his review and see what the categories are. And interestingly, the most recent paper of all that I've just picked up from AMGIC in Press this week, well, this paper doesn't really fit into any of those categories, but it does answer one or two queries that we've had already. And that is about how much patients shed, and this is looking at MRSA, although I'm sure there's similarities with some of the other organisms. And what this group found, and there are some big holes in this paper, believe you me, but that you can't get around the fact that patients are more likely to get MRSA a week after there's been a heavy colonisation pressure. And the colonisation pressure was actually graduated to how much the patient was shedding, because they did systematic screening of near-patient hand-touch sites, mostly the clothes, the linen, the bed rail, etc. So, and it doesn't matter whether you can look for the hand hygiene compliance rate, it isn't there. You can look at how the ward was being cleaned. There was an awful lot of disinfectant and an air purifier being used. You can look at all these things. You can look at antibiotics, and they do mention that in the paper. But you can't get around the fact that you're more likely to get MRSA a week after there's been an awful lot more patients with it. So you've seen this already. It's not Space Invaders, of course. It's VRE floating about in this ITU. But they're not floating about. They're on hand-touch sites, and they are concentrated right next to the patient. So the catchphrase for us in the cleaning world, and I think that probably involves all of you here too, is near-patient hand-touch site. More of that later. Thanks to Phil Carling for this slide. Here's just a few of the examples in a hospital. And, you know, some of those fall in the domestic or housekeeping specification, but some of them fall in the nurse cleaning specification, and therein is a problem. Responsibilities, who cleans what? And are there sites in your hospital in a particular ward where there are objects which are forgotten and which don't fall on any specification? Okay, hand-touch sites. Well, we all know, fixated as we are on hand hygiene, why hand-touch sites are so important, because these are the places to find what we're worried about. These are the high-risk sites, and the closer they are to the patient, the more risk there is. There was a lovely paper published, I don't think it was a microbiologist on it, in a journal called Pediatrics in 2000, and they seeded a bit of inverted cauliflower mosaic virus on a telephone in a pediatric unit. And then you just tracked it over the hours and days to see where it went. And it spread all over the unit on hand-touch sites, all over. Someone's done that in a student flat. The results were too awful to tell you. How well is environmental cleaning being done? And again, thanks to Phil for this gorgeous slide. I love this. Are shiny floors enough? Well, they will answer your aesthetic concerns. Your patients concerned about how clean the hospital is, relating that to how good their treatment is going to be. But is that what we're really interested in now? I think we've gone a bit far along the path than to worry about how clean or shiny a floor looks. Most patients don't get their infections from floors. And yet, of course, this is what's looked at when you walk around with a checkboard looking to see exactly what's being cleaned and whether the floor's clean or not. Who cares about floors? We're going to get shot for that. Phil did this, Phil Carling. He's got this fluorescent stuff, fluorescent goo. I think he's given it a name now. I think it's Dazo, is that right? Yeah. It's a bit sneaky, I suppose. You go and put this goo, which of course is invisible, onto various sites, and then you come back later to see if they've been cleaned away or substantially disrupted. And he's done a huge amount, and he deserves a huge amount of credit for flying the cleaning flag in the States. And what he found, of course, predictably, was that there were traditional sites that were really well cleaned, and they tend to be, you know, the flat surfaces, which are easy to clean. But the little fiddly bits and pieces, the knobs, the buttons, the levers, etc., these were scarcely cleaned at all. And I think he's got a whole raft of papers which show that. And my comment at the bottom, is there a conflict of responsibilities between staff who clean? Yes. Well, maybe it's not a conflict. That's a tough word. Maybe it's actually, well, who cleans that? Well, we don't know. Well, why is it not on a spec? Well, we don't know. Again, more of that later. We need to be able to measure how clean a hospital is. Otherwise, we are going to get nowhere in assessing the role of the environment in hospital-acquired infection. And this is not going to be easy. Okay, let's look at what the food industry have done. They are ahead of us by at least 15, 20 years. Because, of course, if you've got salmonella on a food preparation surface in a factory making sandwiches, just think how many people you could potentially make ill with that. Some people will be okay. Some people will get sick, diarrhea. Some people might even die. Well, I don't think there's that much difference between people who get MRSA delivered to them on hands from a contaminated hand touch site. So if you look at what's going on there, let me just get my pointer. It's this bit here. Turn around. There we go. They use a whole range of sampling techniques, including visual microbiological and rapid methods, and they've got it in a structured HACCP framework, hazard analysis, critical control points pathway, because it means that they might be able to identify a problem with surface cleanliness before they go and poison 5,000 people. I think we've just seen the effects of that across Europe. I wonder what happened there. So what is the difference between the food industry and the hospital? Well, the food industry has to make money and they could be sued and they go out of business. You can't very well sue, well, you can sue a hospital, but it's not going to go out of business. So maybe that's why we haven't actually yet really tackled the role of the environment when you think how sick patients get from contaminated hands on hand touch sites. Right. Okay, this is the tough bit, rocket science. How clean are hospital surfaces? Chris Griffith did this. Chris is a food microbiologist moving over from the food industry into healthcare. Good for him. And we're very pleased he's done so, because it tells us that when you walk around looking at a hospital and it looks clean, that is rubbish from a microbiological point of view. It's also rubbish from the ATP point of view. ATP, of course, is a measure of organic soil. I'm going to say a little bit about that. What is clean? Well, yeah, it looks clean. Have the bins been emptied? Tick. Okay, on to the next ward. That is not good enough, and it is not good enough for the 21st century. We shouldn't actually define whether a hospital is clean or not unless you've got scientific data to show that. Okay, ATP, measurement of organic soil. Very quick, nice handheld gizmo, takes 15 seconds. There are several companies making these, and there are some problems. Let's have a look at the data that we found with a study in a teaching hospital last year. This was looking at a systematic screening of various hand touch sites. Some of them are listed down there for you, on medical and surgical wards, and we did a before and an after in triplicate, looking at ATP ranges, so what the gizmo was telling us on the quantity of organic soil on these high-risk, near-patient hand touch sites. And to cut a very long story short, you can see that there are some aberrant values. In fact, just one aberrant value for the left side of the bed in a medical ward. There we go. And also for a table on the surgical ward there. And that one aberrant reading, and I'll explain why we got that, has skewed the whole thing when you look at all of the results together. So here and here. So before cleaning, 120 from these sites in triplicate. After cleaning, and this is detergent cleaning, 69. So that's okay, because our benchmark was 100 RLUs. Okay? But here and here fail, and that's after cleaning. And the reason why is because the organic soil contains an awful lot of things. It contains our skin cells, and it measures soup spillage, food debris, drinks, body fluids. There was blood on one of these sites, and there was soup on an overbed table, which you couldn't see because it had been wiped up. But it throws all the results into confusion. And I would say that if you want to measure how clean your hospital is, don't just rely on ATP. And if you do, you need to make sure you've got a systematic screening framework, ongoing, you've done a risk assessment, and you know what you're dealing with. Because otherwise, you're going to find that your managers are most unhappy about the results coming out. Okay, microbiological standards. These are dip slides, and of course you can see the colony forming units there, and they can be quantitated. And I say this to the medical students when I show this slide to the medical students, which came from Chris Griffith, and that is, if you were coming into a hospital to have your hip replaced, what would you rather the top of your bedside locker look like microbiologically? And it's clearly not the slide that you see covered in organisms at 45 colony-forming units per square centimetre. In fact, I almost wonder whether 5 colony-forming units per square centimetre is acceptable too in this day and age. But think about the multi-drug resistant gram-negatives we've got, almost untreatable in some places in the world, and we're beginning to see them now too in my hospital. So we put together some standards. We've got 2 standards, and these were really taken from the food industry, and we also looked at work done in the air industry and the bathing water industry as well. So we've got, if you like, a standard saying we don't want these specific organisms in the patient environment, and it's less than 1 and not 0 because of the lawyers. Standard 2, aerobic colony count. Now, why did we include that? Well, I'm sure you have done some environmental screening at some stage, or at least known someone else who has. And of course, if you've got an outbreak, even in the middle of a rip-roaring outbreak of MRSA or whatever, it's actually quite difficult to find the outbreak organism in the environment. A ward is a big place. So we decided, and also because we were not thinking about outbreaks at the time, that we would have a standard 2, which was an aerobic colony count from a hand contact surface, which should be less than 5 colony-forming units per square centimetre. So if you just think about that, think about fingers. I mean, the top of the finger is about a square centimetre. How many colony-forming units of MRSA cause an infection? 4, some data. 7 spores of Clostridium difficile. Are we in the right area? Who knows? We thought we'd check these standards out and see if they worked. This was a 1-year study looking at commonly hand-touched sites on 2 surgical wards, just using the proposed standards. Were we going to find anything interesting? You can see the ubiquitous Iron Brew, which is the Glasgow national drink, on the top of the bedside locker, just to prove this is in Glasgow. What did we find? We found Staph aureus and MRSA, which we used as our indicator organisms, if you like. We found them on lockers, overbed tables, and bed frames. And we also found that we were far more likely to see a larger aerobic colony count from these sites when they were positive for Staph aureus and MRSA. So there seemed to be a link there. What we didn't expect was that there was also a link with bed occupancy. And this was over a year, looking each week at screening and the results from screening and the number of patients on that ward. And there was a significant association. So, you know, you've got what the patients are worried about. Busy, dirty hospitals are a risk. One of these wards was running at 100% bed occupancy half the winter. So, carrying on. We also looked at the standards on an ITU, and there's 8 hand-touch sites which were screened twice every week for 10 weeks. So there were 20 screenings done altogether, and you can see the number of failures there amongst these different hand-touch sites. How many of them exceeded 5 colony-forming units per square centimetre? How many of them produced a coagulase-positive staph? And we added up all the hygiene fails, and of course it was the sites right next to the bed which were failing on a number of occasions. That workstation there, you can see 0, 0, 0. Nobody was ever in the bed next to that workstation. So it's quite nice to realise if the bed's not occupied, then there's obviously not going to be a great deal of contamination. There you go. The blood gas analyser, that was actually just the button, the on-off button on this surgical intensive care unit. And that failed 9 times. You see some of the MRSAs and MSSAs, they're starred. That's because we found indistinguishable genotypes from invasive patient specimens, so blood cultures, tracheal aspirates, wound swabs. We found the same organism in the environment as we did in the patient. Just moving on, there it is. We looked at Staph aureus, we looked at MRSA, we looked at coagulase-negative staph. They were typed courtesy of the Scottish MRSA reference facility, and you can see the timing along the horizontal axis. So these are just weeks. I mean, this was just a 10-week study. It was a student project. I wasn't expecting to find anything. And we found there's a unique strain of MRSA comes in with the patient there, and 1, 2, 3, 4 weeks later, the bucket signifies an environmental site. The other way around. Here's an environmental site. I can tell you exactly what that was. It was a chair. Unique strain of MRSA, and then, look at this, 1, 2, 3, 4, 5, 6, 7 weeks later, it's in a patient's blood cultures. Now, of course, the one thing we didn't do was screen staff, because you need ethical permission for that. So it's quite possible staff were wandering around with these organisms and confounding the project. But it did look to us at the time as if there was a possibility that the environment was actually feeding some of the hospital-acquired infections in this unit. I'll just go back to the conclusion slide. A quarter of all the samples failed the standards, according to what we put through. Once again, the fails were associated with bed occupancy, so the busier the unit was, the more likely you are to have microbial dirt in the environment. And of course, there was an association with Staph aureus. And there also appeared to be a link. It was trending, but it didn't quite reach there. It was only 10 weeks. A link between the environmental data and the incidence of all ICU-acquired infections, so not just staph infection in ICU, coagulase negative staph on lines and so on, the gram-negatives too. This study needs to be done again. It needs to be done for much longer. But certainly, if I answer my own question, do microbiological standards help? Well, they did turn up some interesting things, even if they didn't really help. This was a little study that was done again with a student on an ITU in a different hospital, and this is just to show you which sites came out as the #1 site for contamination, both with higher counts of aerobic colonies and also coagulase-positive staph, bed control in our ITU. We didn't publish this. What we did was we wrote a nurse cleaning specification which prioritized the most frequently contaminated sites so that we knew that we'd got every single site where there might be Staph aureus, etc. And the nurses do that 2 to 3 times a day, depending on which site it is. That's been going for 3 years now. In 3 years, it's a 12-bedded ICU. We've had 2 incidents of MRSA, ICU acquired, no Clostridium difficile, no Acinetobacter, no VRE. Right, more rocket science. Is there a relationship between organic soil values and microbiological values? You know, okay, if you're going to screen the environment, what are you going to choose? But are the two related? I mean, they ought to be. This is Chris's work, Chris Griffith again, and his team, where they actually looked at all the categories of microbial growth, which you've got along the bottom there. So nothing grew here, so you've still got 20% fails according to ATP. So that's good, isn't it? So ATP is measuring something that doesn't grow on an agar plate. This is visual here, this black one here. You can see there's no relationship at all between progressive more contamination on the hand-touch sites and what your visual assessment gives you, which makes sense, really, until you get to here, of course. So you can have up to 40 colony-forming units of whatever it is on a hand-touch site, and it passes. So if you're still fixated on visual assessment, forget that, only from the aesthetic point of view. Now, from the point of view of ATP, there seems to be a sort of a linear relationship. So progressive, more microbiology counts go up, the more you're likely to see your ATP go up. Does that hold? We decided to have a look at that. And if I just go back to this study here, the data in this study, the ATP and the microbial categories data has been slotted into this graph here. So this is the data that you've just seen on the slide. This is the microbial growth categories, and this is the percentage ATP failures just here. And the benchmark, of course, that this particular team used was 250. We used a different system. And when we looked at the benchmark of 250 RLUs for a hygiene pass or fail, this is what we got. So everything passed because that benchmark was too high, if you like. We set the benchmark at 50, and we got everything failing because the benchmark was too low. When our benchmark was 100, you can see that we had roughly the same proportion of passes and fails. So, yes, there is a loose relationship. We did an ROC curve looking at ATP values and microbial growth categories from hundreds of sites screened. And there was a loose relationship, 60% chance that if a site fails a microbiological standard, it will also fail an ATP standard as well. At the moment, ATP is not good enough. The companies are working very hard to refine their equipment, and I have absolutely no doubt that they will come up with a way of measuring not just all organic soil, but the soil we're interested in, which is live MRSA, Clostridium difficile, and so on. And that will happen in the 21st century. Okay, you've heard about this study before. So it was a prospective crossover study using detergent. And what we did there was we upped the frequency of cleaning some of these high-risk sites on the ward. No disinfectant was used at all. We did weekly screening, and we screened the patients as well. We also looked at how many patients had a ward-acquired MRSA infection. And we genotyped everything we found. And that was, all those strains were genotyped blind. These were the screening sites, so you can recognise all of these: clinical equipment, hand-touch sites, sites at the nurse's workstation, and so on. And they were done every week, and they were done when the study cleaner wasn't there. We didn't want Beth, her name was Beth, she's a little Glaswegian cleaner with earrings and a blue rinse. And we didn't want Beth to know where we were actually looking. But of course, this was a ward of 21, 25 beds or so. We didn't do the isolation rooms. There were plenty of lockers to choose from. So it didn't really matter, indeed, if she had come in and seen where we were screening, because she wouldn't have known which one we were going to go for next. This is the middle 6 months of the study. Here are the total aerobic colony counts for the boys' ward. This one here comes down, and so on. And Beth is working on this ward. She's beavering away from 7 o'clock in the morning till 3:30, Monday to Friday only. And what she does is she struggles to get the counts down, but overall, she got the counts a lot lower than for the second 6 months, because here, she moved to the girls' ward, and the counts come down, because she's working like a beaver on the girls' ward. I have to say there were two. She didn't work all the time. She did get some time off. From my point of view, I wasn't really bothered about that. I knew that was going to happen anyway. If you clean more, you're going to see a reduction in microbiological soil. But what we were interested in, what happened to the patients, and this is what happened to the patients. Just here, there was an outbreak on the boys' ward. But some of those organisms were actually unique and not related to any others that we'd had. There were at least 6 patients. 1 patient died. 1 patient lost a leg. And the hypothesis was the sudden accumulation of dirt and soil on that ward was responsible for those extra patients acquiring MRSA. The same thing happened when she left the girls' ward. So over here somewhere, there was a sudden little cluster of MRSA patients, new infections, not colonisation, infection. And that happened 2 or 3 weeks after she left the ladies' ward. I'm going to say a bit more about this tomorrow morning. Okay, you've heard all about that. Here's the genotyping. This was done blind. We sent all the MRSA isolates from the entire hospital, including those from the patients on the study wards and those that we'd found in the environment, to the MRSA reference lab, where Kirsty genotyped the whole lot and put them together in a dendrogram. And what did we find? We found that the environmental and the patient isolates were clustering. We could actually work out where the isolates were going, because occasionally patients moved between those wards in the side rooms. So a male onto a female ward in the side room and vice versa. We could track the progression of indistinguishable and unique genotypes of MRSA between the 2 wards and between the environment and the patient. Well, I think the success of that study was actually about the frequency. And this has come from Mike Rollins, this particular slide. And what he did here was he just took a contact plate from the top of a bedside locker, then it was cleaned, and then he took contact plates at 1 hour, 2 hours, and 3 hours after the initial cleaning had been done. And you can see there what happens. There's nothing on the plate at 1 hour. There's maybe a colony there at 2, and then at 3 hours, of course, you've got that. So to answer the questions and the queries about frequency of cleaning, and this was actually, I think, steam cleaning or detergent cleaning, it wasn't disinfectant, then it looks as if what we're doing at the moment in our hospitals, which is, a good clean in the morning and then a spot check later on, which is what happens in UK hospitals, that is nowhere near enough in a high-risk patient environment. Not enough at all. And there's a letter in ITCHE, Aldeyab et al., where it shows you really quite nicely how quickly specific high-risk sites are being contaminated on an ITU. Okay? Well, okay, so cleaners aren't doing their job properly. That's rubbish. Most cleaners are just like us. Some of us don't do our job properly. Some of us are really good. Most of us are average. Same with cleaners. Some of them aren't very good. Some of them are brilliant, like Beth. Most of them are doing a good job. Professional cleaners know where dirt is. They should be respected. They are part of the infection control team. I don't think people can stand there with a clipboard watching cleaners clean. I really do hope that isn't the future. I think we can get a bit more scientific than that. We can measure it with ATP, we can improve it with ATP, and you've heard about this study already from John, which is John's study with ATP, and an educational program for the housekeepers. And of course what happens is, after they know about how important they are and the fact that their work is being measured with ATP, there is an improvement. So if you want an improvement intervention, then ATP is good. Hand hygiene compliance. Well, probably about the less said about that, the better. After all, there are hundreds of posters and presentations here about getting people to clean their hands. But there's a comment I want to make about hand hygiene compliance. Is this hand hygiene or cleaning? 90% compliance after a couple of months. Good, isn't it? If you manage to get everybody to clean their hands properly in your hospital like that, you would be doing really well. Of course, this isn't hand hygiene. This is Phil Carling's fluorescent goo in enticing housekeepers to clean better. And is this maintained? Yes, it's maintained. So I think at the moment, Semmelweis is in the lead, 1-0. Florence Nightingale is the nil bit. And I think it's about time we reinvented hospital cleaning, because I think the surfaces, including this that I'm touching now, are just as important as hand hygiene. Okay, they're not dynamic, they don't move. But what about the patient's hands? What's the patient touching? Near patient hand touch sites. Does anybody clean the patient's hands? No. Can the patient clean their own hands? They can't get out of bed and go to the nearest sink. I think we can agree on standards. We know it's achievable. Phil's shown that. We know it's measurable. Okay, microbiology ATP is not perfect yet, but this is the beginning of a new science of hospital cleaning. We've only just started. Hand hygiene's been going a long time. It's easy to learn, it burns calories. It's cost effective. I'll show that tomorrow morning. It works. And you can wipe over the near patient hand touch sites around a patient quicker than you can wash and dry your hands properly. Believe you me, I've done it. So we do need both together, and I think Marcus touched on that. And of course, John showed this slide too. So you've seen this 3 times, this beautiful epidemiological study from Mary Hayden, where you can actually see the result of both hand hygiene and cleaning. Fantastic. Maybe the two can't be separated. Well, in that case, can we have 1,000 posters next year at the next ICPIC on cleaning? What should we do? You still need the visual side of things. That's what patients see. That's what patients judge you by. If you want to directly observe cleaners, that's fine. Write it up as a trial. Send it in to be published. Let's see what you found. Do we have to supervise cleaners? No, maybe, I don't think so. Clever cleaning schedules. This is my favourite. You target the high-risk sites. You frequently attack them. And you do it with detergent. You do it with microfiber, provided you can decontaminate the microfiber properly. And I think wiping away, the physical action of wiping away 4 colony-forming units of MRSA from a bed control, why not do that rather than splosh disinfectant all over it? And so on. Fluorescent gel, the ATP systems, microbiology, maybe all of them in a structured Hachette framework, just as the food industry do. Your hospital will be a leader. Something extra for the 21st century? Watch this space. I'd like to say thank you to all the people that have supported me and allowed me to come to this conference. I have now run out of study leave completely. And tomorrow morning, we've got a Grime Watch session at 8 o'clock in the morning. It's the nasty toxic disinfectant. That's not the nasty toxic John Boyce, by the way. That's the nasty toxic disinfectant versus the eco-friendly detergent. It's very early. Be there. Thank you very much for listening.